Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on considerations for long-acting injectable PrEP, featuring Dr. Jason Schafer, who is a professor and vice chair at Jefferson College of Pharmacy, Thomas Jefferson University in Philadelphia, Pennsylvania. He'll take us through a case study of a patient who recently switched to long-acting injectable cabotegravir for PrEP and is anticipating missing a dose. He will explore the latest data and recommendations for managing key clinical considerations for patients on long-acting PrEP. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Schafer.
Welcome to this Key Decisions in HIV presentation. This presentation is titled Considerations for Long-Acting Injectable PrEP. My name is Jason Schafer. I'm a pharmacist, professor and vice chair at the Jefferson College of Pharmacy in Philadelphia, Pennsylvania. Let's begin our discussion with a case study. This is a 35-year-old cisgender man who has sex with men, having difficulty adhering to daily oral PrEP, and recently switched to long-acting cabotegravir. He presents for his bi-monthly injection and says he is traveling for his sister's wedding and will miss his next planned injection date by 10 days. His most recent laboratory data suggests that he is HIV negative, his antigen antibody test is negative, and his HIV viral load is negative as well. He is immune to hepatitis B and does not have hepatitis C. His serum creatinine is 1.3. His ALT and AST are within normal limits for a male. His BMI is 26, and his A1C is 4.9%. Cabotegravir has been recently approved by the FDA for PrEP in at-risk adults and adolescents weighing at least 35 kilograms to reduce the risk of sexually acquired HIV infection. It should be initiated as 2 injections administered 1 month apart, and then every 2 months thereafter. Patients can either start with cabotegravir injections right away, or they have the option of taking oral cabotegravir for 4 weeks to assess how well they tolerate the drug. As patients and providers start to consider the use of long-acting injectable ART, particularly cabotegravir for pre-exposure prophylaxis, it's important to try and address as many of the concerns about using these agents as much as possible. Some of the concerns that have been highlighted include patients not returning to clinic on time for injection appointments, providers worrying about the risk of resistance for patients who are non-adherent to their injections, patients missing doses for one reason or another, maybe moving out of the area or switching to a different provider, certainly worrying about drug interactions and perhaps comorbid conditions or co-infections like tuberculosis. Patients who want to stop their long-acting injectable medicine and maybe switch to an oral medicine, and then thinking about that oral lead-in before starting injections. And so let's try to address some of these concerns in the following slides. So first, let's talk about the dosing and administration of long-acting cabotegravir for PrEP. We know that the dose of cabotegravir is 600 milligrams. It's administered as 1 3 ml intramuscular gluteal injection. For PrEP, the 30-day oral lead-in is optional prior to the first injection. In the clinical trials that led to the FDA approval of cabotegravir, both HPTN 083 and 084, that lead-in period that was included didn't really reveal any significant tolerability issues. And so it's optional to use the oral lead-in, but it's really not a requirement. People can start with their injections right away without that oral lead-in provided. The second injection of cabotegravir is provided 4 weeks after the first injection, and then subsequent injections are provided every 8 weeks thereafter. It's also important to note that the needle size that's used really does matter, particularly for patients of different BMIs. So if a patient has a BMI of less than 30, the 1.5-inch needle can be used. However, if their BMI is over 30, it's recommended to use a 2-inch needle to make sure that the medicine is administered properly. One of the most common clinical concerns with long-acting cabotegravir for PrEP is the risk of missing a dose and what the consequences may be. There are specific instructions on what to do if a patient plans to miss a dose, and these instructions can be found in the cabotegravir package information. So if a person plans to miss a dose, especially in that 2-month continuation phase of their injections, and they are going to miss that dose by more than 7 days, the instructions would be to give oral cabotegravir 30 milligrams daily for up to 2 months to replace one missed injection. So that first dose of oral cabotegravir should be taken 2 months after the last injection dose. And we restart injections on the day oral dosing ends or within 3 days of that completion of oral dosing. An alternative oral PrEP regimen is going to be recommended if oral PrEP intervals are necessary for longer than 2 months. Cabotegravir as an oral medicine really isn't approved for pre-exposure prophylaxis, only to kind of cover these missed dose situations. And so if a person needs to continue on oral PrEP, they should be switched to a tenofovir-containing PrEP option. And so let's go back to our case. Remember, this is a 35-year-old cisgender man who has sex with men. He had difficulty adhering to daily oral PrEP and recently switched to long-acting cabotegravir. He's here for his bi-monthly injection, but says he's traveling for his sister's wedding and will miss his next planned injection date by 10 days. How should this patient's planned missed dose be managed? And the correct answer to this question is to administer cabotegravir today, start oral PrEP in 2 months, and restart cabotegravir when he returns. It's important that supplemental coverage with oral cabotegravir for PrEP be provided when the injection dose is missed by more than 7 days. So the first dose of oral cab should start approximately 2 months after that last injection dose, and injections can be restarted once the patient returns. So another clinical concern with long-acting cabotegravir for PrEP is, what do we do in instances when patients want to stop their long-acting injectable medicine? Well, it's certainly okay for patients to stop if they would like to, but they should be assessed for ongoing risk of HIV exposure. If they do have ongoing risk of HIV exposure, they should be provided oral PrEP. First, we should counsel people about the long duration of declining cabotegravir levels, because this is a long-acting medicine, and the medicine will stay in the person's body for many months. And so if the person acquires HIV infection during a time period when there's declining or perhaps suboptimal cabotegravir levels, there's a risk that resistance to cabotegravir could occur if the person acquires HIV infection. So if they do have ongoing risk of HIV exposure, we should give oral PrEP with either TDF-FTC or TAF-FTC. And we can begin that oral medicine within 8 weeks after the last CAB injection. We'll, of course, follow individuals quarterly for 12 months to assess PrEP needs, to see if they still want to remain on oral PrEP or perhaps switch back to the injectable medicine or stop PrEP altogether. And we should be completing HIV testing during that time frame as well. Another concern with long-acting cabotegravir for PrEP are the delays in diagnoses that were observed in the HPTN 083 and 084 studies. Specifically in HPTN 083, HIV detection with antigen antibody testing was delayed in comparison to qualitative HIV RNA testing. Specifically, in those receiving cabotegravir, the delay was 62 days for baseline infections and 98 days for incident infections. Importantly, there were delays that were also observed in patients receiving oral pre-exposure prophylaxis in the 083 study, specifically 34 days of a delay for baseline infections and 31 days for incident infections. The reason for the delays may be that antiretrovirals that are used for PrEP can suppress early viral replication, which can affect the timing of antibody development and diminish the efficacy of our tests. As a result, HIV RNA testing is now recommended for routine screening of HIV infection during the use of oral and cabotegravir injectable PrEP. So whether a patient's receiving cabotegravir or oral PrEP, HIV RNA testing is now recommended for routine screening. Patients on daily oral PrEP should be tested at least every 3 months, and patients receiving cabotegravir injections should be tested every 2 months. Another clinical concern about the use of long-acting cabotegravir as pre-exposure prophylaxis is just how to implement the practice in a routine HIV clinic. Well, we can learn a little bit from the customized study. Now, the customized study was designed to look at how to implement cabotegravir plus rilpivirine for the treatment of HIV infection, but I think a lot of the lessons that were learned in the customized study would be applicable to implementing long-acting cabotegravir for PrEP. In the study, they found that successful implementation was probably the result of really good staff communication, teamwork, the use of a web-based treatment planner, and then for patient adherence, making sure that patients really are aware and can receive all of their doses of medicine. They relied on good communication about the dosing window, making sure that people on staff as well as the patient were included in that conversation and understood what the dosing window was. They were able to have effective appointment reminder systems, and they had designated staff for appointment tracking. All of these lessons can certainly be applied to probably successfully implementing long-acting cabotegravir for pre-exposure prophylaxis as well. And now we'll hear from a patient who is on oral pre-exposure prophylaxis, who is considering long-acting cabotegravir, but does have some questions.
If I don't get it on the 1st of every month, if I have to get it like on the 5th 1 month and then the 1st the next month, will that affect drug levels? Will that affect its potency, its ability to work? What happens if I'm out of state, out of country for some reason and I'm unable to get it? If missing, that one dose, am I going to be essentially off of therapy for a full month, or will it pick right back up as opposed to when you're taking the oral PrEP? If you miss a day, you just kind of go right back to it the next day. Like how that's one of my biggest questions is if there's a lapse in that once monthly injectable due to finding a site that can provide it, will that affect its efficacy and will that affect my adherence towards it?
And to summarize our take-home points from this presentation, long-acting cabotegravir joins FTC and TDF, FTC TAF, as a recommended PrEP option in clinical practice guidelines. The implementation of long-acting cabotegravir for PrEP will require interdisciplinary collaboration, shared decision-making with patients. We should be aware of the unique characteristics of long-acting cabotegravir, including how to manage missed injections, how we're going to stop medications if necessary, and how to screen for HIV in patients receiving cabotegravir. Go online for more CCO activities on key decisions in HIV care.
Thank you to Dr. Schafer, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.